patient record. The patient record contains a variety of clinical information. The actual organization of information within a medical record may vary slightly by institution. Uniformity in how patient charts are organized. The following table lists the major sections of the typical patient record and the information you can find in each section. While a complete review of the medical record is important to many aspects of respiratory therapy, the NBRC will expect you blah 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 blah. Okay. Admission or face sheet. Patient's address, name, birth date, place of birth, race, nationality, marital status, next of kin, religion, occupation, and employer. Health insurance information may include admitting diagnosis. Informed consent. Consent forms signed by the patient and witness for various diagnostic and therapeutic procedures during those for bronchoscopy and surgery. DNR or advance directives. Properly signed and witnessed do not resuscitate DNR. Do not intubate DNI and or advance directives. Patient history. History of present illness to include chief complaint, description of symptoms, frequency, duration, quality, severity, onset, and features which aggravate or alleviate discomfort. Past medical history to include childhood diseases, major illnesses, and hospitalizations, surgeries, allergies, blah, blah, blah. Okay. Family disease history. Okay, so patient history includes the history of present illnesses, main or chief complaints, past medical history, family history, social history to include education, finances, family relationships, diet, exercise, cultural background and religious influences, living situation and social activities or support, tobacco, alcohol, or drug use, recent travel or other event that might impact health, occupational and environmental exposure history to include all job-related activity, respiratory dysfunction, as well as extra occupational exposures to toxic or irritating substances. Review of systems, respiratory, to include cough or hemoptysis, sputum production, chest pain, dyspnea, hoarseness, or voice changes, dizziness, fading. Okay, so patient history includes chief complaint, past medical history, family disease history, social history, which is drug abuse and other stuff, occupational and environmental exposure history, and the review of their respiratory system, like if they're coughing and stuff like that. So that would be a good question. So six things to include in the patient history would be chief complaint, past medical history, family history, social history, occupational and environmental exposure history, and I don't know how you word that one, how review of their respiratory system. Okay, progress note. Progress note is discipline specific. It has discipline specific notes generally entered at frequent intervals daily on a patient's progress and planned from physicians and allied health professions, including RT. Nutrition and social work normally includes differential diagnosis. So the progress notes normally includes differential diagnosis. Physicians' orders, doctors' diagnostic and therapeutics orders, including those pertaining to respiratory care. All incomplete or unclear orders should be clarified with the prescribing physician. Surgical and anesthesia record. A summary of any surgical procedures and anesthesia, including post-anesthesia recovery. Surgical and anesthesia record. A summary of any surgical procedures and anesthesia, including post-anesthesia record. That makes no sense to me, but whatever. Medication record. A complete listing of all drugs, dosages, routes, and dates or times of administration received by the patient. Lab results. CBC. Coagulation studies, PT, PT. It should be PT, PTT, and INR. Electrolytes, cardiac biomarkers, metabolic tests, microbiology, sputum, urine, ABG results may also appear here. That's easy to remember. Imaging studies. X-rays, including chest X-rays, CT scans, MRI, ultrasound studies, angiography, as well as PET and VQ scans. ECG record, the results of ECGs, therapy or RT, respiratory therapy charting, results of PFTs and sleep study results as an alternative to being with lab results. ABGs may also be in this section. Documentation related to other disciplines such as physical and occupational therapy may be included. Flow sheets. Nurses' subjective and objective record of the patient's condition, including vital study, where did I see study? I don't know. Including vital sign trending and fluid intake or output, INO, and hemodynamic monitoring such as CVP, PAP, and PCWP. Patient education documents assessment of the patient's learning ability and needs, as well as all education provided to meet those needs while hospitalized may be incorporated into the nursing notes. Okay, so outline of a complete health history. You have the demographic data, like the name, date of birth, age, address, race, blah, blah, blah. You have the date or source of history, estimate of reliability of historian, brief description of patient's condition at the time of history, chief complaint, the reason for seeking medical care, present illness, chronology, and description of each symptom. Onset, the time, the type, and the source and setting that the illness started. Frequency and duration, location and radiation, severity, quantity, quality, character, aggravating or alleviating factors, associated manifestations, history, childhood diseases and development, hospitalization, surgeries, injuries, accidents, blah, blah, blah. Okay, understood. Accepting and verifying patient care orders. Your blah, blah, blah will dictate if you can accept orders from other healthcare professionals, general, accepting patient care orders. If you can accept orders, they must come from an authorized healthcare provider with prescribing privileges. You cannot accept orders transmitted to you via unauthorized third parties such as registered nurses. If an order is transmitted to you via a third party, you must verify the order in the patient's chart before proceeding. Institutions, orders written by medical students must be countersigned by a physician before you are allowed to carry them out. You should not accept blanket orders. Example of a blanket order include continue previous medications or resume preoperative orders. I did not know that. Regarding verbal or telephone orders, if the doctor is in the house and the situation is not an emergency, it's best to secure a regular written order. If a verbal order is required and you are authorized to take it, you must avoid transcription errors. To properly take a verbal order, the Joint Commission recommends that the following procedures followed. While speaking with the prescribing physician or healthcare provider, write or type the complete order in the applicable section of the patient's record. Read the order back to the originator exactly as written and clarify as needed. Have the originator confirm the accuracy of the order as read back. Time and date the order with the name and credentials of originator. Specify, read back, and confirmed. Provide your signature and credentials. Verifying orders. Regardless of their source of route or route of transmission, it is your duty to assure that all foster care orders are accurate and complete, although the components vary according to what is being prescribed. A complete written order generally must include the following elements: date and time of order, name of therapy or diagnostic test being prescribed, requisite details for therapy or conditions for diagnostic testing, frequency of therapy or testing, name, signature, and credentials of the ordering healthcare provider. Okay, that's a good question for a flashcard. So a complete written physician order must include 1, 2, 3, 4, 5. Date and time, name of therapy or diagnostic test being prescribed, details of therapy or conditions for diagnostic testing, frequency of therapy or testing, name, signature, and credentials of the ordering provider. Or instead of saying of the ordering provider, just say of the physician. If the order is a drug, it must contain the following additional information: drug name, route of administration, dose, or concentration. For oxygen, the liter flow or FI at 2% should be included. So that's another good one. For a flashcard, if the orders for a drug include drug name, route of administration, dose, or concentration. If the order is for mechanical ventilation, if the order is for mechanical ventilation, it's recommended that it include at least one or ideally both of the following: desired range for PaCO2 and/or desired range for PaO2 or oxygenation status. That's a good one. If the order is for mechanical ventilation, the ARC recommends that it include at least one or ideally both of the following: desired range for PaCO2 and/or desired range for PaO2 or oxygen saturation. That's a good one. Good flashcard question. Ventilator variables to initiate or manipulate in order to achieve desired blood gas results. Example mode, tidal volume, airway pressure, ventilatory frequency, or FiO2. So this could make one or two flashcards, or even break this first one up to make even three flashcards. Because my teacher always saying this stuff. Okay. Should any of these elements be missing, the order is incomplete and you should contact the prescriber for clarification before implementing the request. The same procedure applies if the order falls outside established institutional standards. For example, if the order specifies a drug dosage higher than that recommended for the patient's size or age, or includes a ventilator mode or setting not normally applied in similar cases, you should contact the physician and request an explanation before proceeding further. Medication history. The medication history is typically part of the patient's overall medical record. It is usually recorded upon admission to the hospital. The medication history provides a record of all medications and related substances taken by the patient, including the following: drugs, prescriptions, over-the-counter medications taken by the patient, vitamins, herbal products or diet supplements taken by the patient, immunization, potential abused substances. Okay, in addition, a good medication history should provide related information on drug allergies and adverse reactions, as well as the patient's compliance with or understanding of the medications and methods of administration. A good flashcard for the medication would be this one. Where in the medical record would one go to find information on a patient's understanding of the drugs they are taking and their methods of administration? And then the answer is the medication history. History provides key information on the prescribed or over the counter medications being taken by the patient, as well as vitamins, herbal products, which is basically a copy and paste from what I just read right here. And it says should also provide drug allergies, adverse reactions, compliance with and understanding of the medication and methods of administration. That's a good example of a card, or you can just copy and paste that one. Okay. Obtaining an accurate medication history is the first step in medication reconciliation. That was on my worksheet. Obtain an accurate medication history is the first step in medication reconciliation, a major safety goal of the Joint Commission. So that could be a question or a flashcard. Medication reconciliation is a process ideally implemented across the continuum of care that compares what drugs the physician orders to those that the patient is taking. What? Medication reconciliation is a process ideally implemented across the continuum of care that compares what drugs the physician orders to compared to those that the patient is already taking. Okay. The major goals of medication reconciliation are to 1. Avoid or correct discrepancies between physician orders or prescriptions and drugs that the patient is actually taking. Prevent medication errors, adverse drug reactions, and potential harm. That's another good flashcard. Patients at higher risk for these potential problems, and thus those for whom an accurate medication history is most essential, include the following: patients with severe or unstable disease states, patients receiving drugs with narrow therapeutic indices, example theophylline, patients treated with complex drug regimens, example asthmatics, patients whose established medications have been altered, elderly or pediatric patients, patients identified as non-compliers, patients with language or reading difficulty. Normally, the medication history is obtained via interview. Often the interview occurs after the patient completes a form like the UCLA one linked to the above, which is the one from Canada. In patients with a depressed level of consciousness or severe agitation, the relevant information may need to be obtained from the family members. It also may be useful to either obtain information on the pharmacies where the patient has prescriptions filled, or request that a family member provide the hospital pharmacy with all of the patient's current prescription vials for review. There was a test question on that, I can't remember it though. Some examples of medication history considerations pertinent to the care of patients frequently seen by the respiratory therapists include the following. This is on my worksheet. Asthma or COPD patients. Some medication history considerations are patients' understanding of controllers versus relievers, patient compliance with controllers, frequency of use of PRN relievers as needed relievers, use of theophylline narrow therapeutic index, long-term use of systemic steroids, potential side effects, techniques, effectiveness of inhaled agents. Patients with respiratory infections. Considerations include prior antibiotic regimen as potential cause of supra or drug-resistant infections, non-compliance with antibiotic regimen, potential cause for failure. Cardiac patients, chronotropic or inotropic cardiac agents, and potential interaction with inhaled beta agonists. Diuretics, effect on lung water, acid-base, and electrolyte balance. Or trauma patients, considerations include opioid analgesics, potential depressions of consciousness or respiratory drive. You can try to make a flashcard from that. I don't know. It's kind of a lot of information to remember, but go ahead, make as many as you want from that. You can make 1, 2, 3, 4, or more. Okay. Oh gosh. Okay. Advance directives and do not resuscitate orders. The Patient Self-Determination Act requires that hospitals provide written information to patients explaining their right to have an advance directive. An advance directive allows patients to participate in decisions concerning their healthcare should they become unable to make informed decisions. Advance directives are recognized in all 50 states. There are two forms of advance directive: instructive and proxy. An instructive advance directive gives instructions to allow or restrict therapies. This can take the form of a living will that lists or limits the level of care that the patient desires should he or she become incapacitated or terminally ill. A living will give the patient the right to avoid unwanted or futile medical procedures or care at the end of life. The second type of advance directive is a proxy directive. In a proxy directive, the patient gives a person the legal authority to make decisions regarding the provision of healthcare should the patient no longer be able to do so on his or her own. A proxy directive is also known as a durable power of attorney for healthcare, DPAC, DPAHC. If a patient does not have a DPAC, most state law provides for healthcare decision-making by a surrogate, usually the patient's spouse. If there is no spouse, then a patient or nearest relative is designated surrogate. In some states, a patient's significant other may not have the legal authority to make healthcare decisions unless they have been designated through a DPAC. For this reason, a DPAC is essential for patients who have no close relatives or are involved in partner relationships not recognized by state law, like a common law wedding or something, a common law spouse. Anyways, instructive and/or proxy advance directives are usually obtained at the time of admission and should be included in the patient chart. All healthcare providers should be aware of their patients' advance directives and have a legal obligation to follow them. Patients can change or cancel an advance directive at any time as long as they are considered of sound mind to do so. Being of sound mind means that the patient is able to think rationally and communicate his or her wishes in a clear manner. Normally, changes must be made, signed, and notarized according to the laws of the applicable state, with all copies of previous advance directives destroyed. Patients who do not have time to put their changes in writing can and should make them known to both medical personnel and any family or friends as soon as possible. Usually, wishes that are made in person will be followed in place of the ones made earlier in writing. That was a test question that I had. Anyways, I was gonna look up the test question, but whatever. Um, because state laws differ regarding the specific requirement for a legally binding advance directive, the legal responsibilities of healthcare professionals to their patient regarding healthcare decision making can vary. To ascertain their legal responsibility to their patients regarding advance directives, RTs therefore should consult their institution's specific policy. In other instructions, medical personnel can legally presume that patients want life-saving treatment. Using an advance directive, patients have the right to refuse such intervention. Usually, a do not resuscitate DNR order results from an instructive advance directive indicating that the patient has decided to refuse CPR should he or she suffer a cardiorespiratory arrest. Alternatively, patients can simply tell their doctor that they don't want to be resuscitated. A proxy or surrogate may also request that CPR not be performed. In either case, informed consent of the patient or the patient's surrogate is required. Once obtained, the attending physician places a DNR order in the patient's medical chart. In most states, if a patient is incapacitated and there is no surrogate, a physician may write a DNR order with the concurrence of a second examining physician. DNR orders are accepted by doctors and hospitals in all states. In most states, DNR orders accompany the patient when transferring to another healthcare institution and will remain in effect until new orders are issued. That was a test question I had too. If they transfer to a different hospital, will their DNR still be applicable? However, in hospital, DNR orders do not necessarily apply outside healthcare institutions. See, that confuses me. Whatever. A patient, you can make a flashcard on that if you understand it, but it's a bit confusing for me. I can find the test question and you can make a flashcard with that, but whatever. A patient or surrogate may revoke a DNR order by a written or oral request to any healthcare provider. Oops. So that was another test question I had. The healthcare provider must immediately notify the attending physician, must immediately cancel the order. Okay, so I found the test question. It says, while setting up the ventilator, the patient mouths to you that they do not want to be placed on any life support system. What would you say to this patient? That was my test question. And here's the answer, that you would notify the attending physician and must cancel the order. Okay. Formal or informal directives such as a slow code or code gray bypass the patient's rights and place an unfair responsibility on staff. Directives like these should be avoided. Physicians who wish to modify normal CPR procedures should write clear orders and bring them to the attention of applicable healthcare personnel. Key points. Advanced directives allows patients to participate in decisions concerning their healthcare should they become incapacitated. Advanced directives, living wills and/or DNRs should be located in the patient's chart. All healthcare providers should be aware of their patients' advanced directives and/or DNR orders. All patients have the right to refuse resuscitative efforts. A separate advance directive is not required before a DNR order can be entered, although it simplifies the process. So you can make flashcards with these. A DNR order must be made in writing and placed in the patient's chart by the attending physician. Resuscitation efforts should be begun when in doubt or when written orders are not present. All patients have the right to revoke a DNR at any time by written or oral request to any healthcare provider. While a DNR order on a chart is acceptable in a hospital, it's not appropriate outside the hospital, example for use by EMS providers. Different states have different pre-hospital DNR statuses. That is the exact same dialogue to me to the exact same thing as before. Okay. Physical examination relative to the cardiopulmonary system. Example, vital signs and physical findings. So I'm going to do the normals for vital signs. The interpretation. Okay, that's a lot to remember. Normal vital signs for body temperature. Normal for oral is 98.6 degrees Fahrenheit or 37 degrees Celsius. For rectal, 5 degrees Fahrenheit. Heart rate for newborns is 120 per minute. For kids 10 years old, it's 90 beats per minute. For adults, the normal heart rate is 75 beats per minute, but the notable range is 60 to 100 beats per minute. Like, I know this, you don't have to make a flashcard on that. Respiratory rate for newborn is 50 beats per minute, breaths per minute, which is 40 to 60 breaths per minute. Kids 1 year old, 30 breaths per minute, or 25 to 30. For some reason, I keep skipping the preschool. Don't really care for it because I don't have like a number to it. Kids 10 years old, respiratory rate of 16 breaths per minute, or 15 to 20 breaths per minute is the range. And for adults, it's 15 breaths per minute, or 10 to 20 breaths per minute. In class, my teacher taught us 12. Blood pressure. Premature infants, it's 50/26. Newborns. This is way too much to remember. Sheesh. But adults, it's 120/80. With the normal range for systolic of 100 to 140 and diastolic of 60 to 90. Sleeping heart rates lower for infants and children. In addition to heart rate, you assess the heart rhythm. Is it regular or irregular? The amplitude or strength. Are there any changes in the amplitude of the pulse in relation to respiratory rate or respiration? Are there changes in amplitude from one beat to another? And any abnormalities? Are there palpable vibrations, thrills, or bruits? Mistakes causing false high blood pressure measurements. Too narrow a cuff. The cuff is too narrow. What does that even mean? The blood pressure cuff is too narrow. How does that give a false reading? Yeah, I don't know. The cuff applied too tightly or too loosely. Excessive pressure placed in the cuff during measurement. Inflation pressure held in the cuff for too long. Incomplete deflation of cuff between measurements. Yeah, I know that, except for that one. Troubleshooting changes in vital signs. Hypotension. A possible problem would be a decreased venous return caused by positive pressure, which is mechanical ventilation. What you'd evaluate the fluid balance and possible need for filling of vascular bed. So that's a good flashcard to make. So it could be what is a possible cause of hypotension and what should you do to correct it? The answer could be possible cause of hypotension is decreased venous return, example caused by positive pressure, and you could evaluate the fluid balance and possible need for filling of the vascular bed. Hypertension. Anxiety responds to decreased PaO2 or decreased PaCO2. Reassure, alleviate fear, check patient ventilatory system. If not easily corrected, obtain and evaluate ABG value. You can skip that one. Respiratory swing of blood pressure, decreased venous return caused by positive pressure. If systolic or diastolic pressures indicate inadequate perfusion, evaluate fluid balance and consider filling vascular bed, which is the same as hypertension. New arrhythmias, possible cause could be anxiety, decreased PaCO2, or increased PaCO2 and decreased venous return. You reassure, you alleviate the fear, you check the patient's ventilatory system, obtain and evaluate ABGs, you check other hemodynamics parameters for adequacy of perfusion. Large swings in CVP or PCWP, decreased venous return is a possible cause of that. You check other hemodynamic parameters for adequacy of perfusion. Decreased urinary output. Possible causes decreased renal perfusion or increased ADH. Can make one for this one. So what you'd evaluate other hemodynamics parameters for adequacy of perfusion. So that's a good one to make. Okay. Possible causes infection, atelectasis, increased metabolic rate caused by fighting the ventilator, overheated humidifier. Treat infection, review precautions, plugs. Check the placement of the ET tube or the ET tube position. You check sensitivity and patient triggering efforts, settings. Check temperature of humidifier heater. You can make one for that. Good flashcard. Okay, weight gain. Fluid retention caused by positive pressure ventilation. Increased ADHD. Where do I see ADHD? ADH. Check other hemodynamics parameters for adequacy of perfusion and consider diuresis. That could be a good flashcard. Changes in respiratory rate, altered settings. So you can make a flashcard for all these. Changes in respiratory rate. Altered settings, change in metabolic needs, anxiety, sleep. Thing you can do, you can check the ventilator setting, evaluate patients, mature, alleviate fears, normal observation. Accessory muscle use or paradoxical breathing. Possible cause, increased work of breathing, and ventilator desynchrony could cause that. What you can do, you can increase support level, provide pressure support ventilation, increase inspiratory flow or sensitivity, and eliminates auto PEEP. So that's a good flashcard too. Okay, so physical findings is the last one, then I'm going to end the video for the session. Because with these tables, I don't feel like I'm learning it. I had to like memorize these. But these are stuff I need to know. Okay, so acute airway obstruction. Initial impression, patient appears acutely ill. On inspection, you will see the patient is using accessory muscles to breathe. On palpitation, you will notice reduced expansion. On percussion, you would notice increased resonance. On auscultation, you will notice expiratory wheezing. Possible cause could be asthma or bronchitis. I guess I could make a fill in the blank thing for this. So you don't need to make a flashcard for that, so I'm gonna skip it. Let me see these to see if they're a lot. Okay. Assembly and troubleshooting of pleural drainage systems. Description. Modern pleural drainage systems are easy to use disposable single patient units that provide all the functionality of old 3-bottle designs with additional safety and monitoring features. Choose the correct unit for the patient. Aseptically remove the unit from its packaging, being sure not to touch any tube connectors or internal surfaces. Hang the system from the patient's bed using the unit's wire hangers, or use the attached floor stand to position the system below the patient's chest level. Be sure not to let the connecting tubing contact the floor. If suction is required, so pretty much this is how to use a chest tube. Cool beans. Fill the water seal. I don't want to read anymore. Okay. Okay, I'm gonna skip that one too, because boring, dry information. This all is boring, dry information, but whatever. Okay. Hopefully this will be the last one. Okay, so insertion and troubleshooting of endotracheal tubes. Insertion, oral route. Assemble and check the required equipment. I'm gonna do this in class tomorrow, so this would be good to read. I can last that long. Okay, assemble and check the required equipment. Pretty much you're gonna check if it's intact and there's no leaks or holes, puncture, blah blah blah. So you make sure you have oxygen, a bag valve mask resuscitator, suction equipment, a stylet, water soluble jelly, a syringe, you know how to say whatever, local anesthetic, and the correct sized ET tube. Plus an extra one, which is larger and smaller, just in case. And you also check for cuff leakage and laryngoscope and blade. The size of the blade should match the size of the patient. In general, blade size number 4 is for a large adult. Blade size number 3 is for an adult or an adolescent, average adult. And a blade size number 2 is for a child. So first things first, you pre-oxygenate with a mask and or manual resuscitation, bag valve mask resuscitator. Then you suction the mouth and throat as needed. You lubricate the tube with the water soluble solution. So you put, oh yeah, I remember doing this. So you just pretty much dip this end with the balloon inflated. Dip this end in the water soluble jelly. Then you place the tube with a marker at about 23 centimeters at the teeth for adult males or 21 centimeter for females, meaning you put it down the patient's throat. Then you quickly inflate the cuff with a syringe of 1.5. No, that's a different one. You pretty much just inflate the cuff with air, and then you connect the bag mask valve resuscitator to this end and ventilate, and you listen for breath sounds. And you determine the proper tube placement by listening, auscultation, and then you can connect a CO2 analyzer on the tip to see if the patient exhales CO2, and then you order a chest x-ray. And you secure the tube with tape or a face strap, then till extubation. Troubleshooting, okay. Troubleshooting endotracheal tubes consists of ensuring correct placement and patency. To check placement immediately, ventilate with a bag valve resuscitator. If breath sounds are not the same on both sides, carefully withdraw the tube a centimeter or two, reinflate the cuff, and check again. So that is a good flashcard for How to check tube placement immediately. And the answer would be to ventilate with a bag valve resuscitator, and then if the breath sounds are not the same on both sides, deflate the cuff and carefully withdraw the tube a centimeter or two, reinflate the cuff, and check again for breath sounds on both sides. If the breath sounds are not heard or the stomach distends, remove the tube immediately and re-intubate, as the tube is most likely in the esophagus. So those are two good flashcards. If it is difficult to ventilate the patient, establish the patency of the tube by attempting to pass a suction catheter. If the catheter will not pass, deflate the cuff and try again. If this relieves the obstruction, reinflate the cuff with only enough air to seal the trachea, usually 20 to 30 centimeters of water cuff pressure. If the above does not establish patency, remove the tube and suction the patient well and reintubate. If a loud leak is heard or observed, reinflate the cuff with just enough air to seal the trachea, usually 20 to 30 centimeters of water cuff pressure. If the leak reoccurs shortly, examine the can be bypassed by inserting a blunted small gauge needle with lower lock hub into the palate line with a 3-way stopcock attached. This can be used to maintain pressure in the cuff without the potential problems caused by removing the tube and reintubating. If the palate line and inflation port are intact, the cuff may have developed a leak. In this case, the tube will have to be replaced. Okay, so from this page, a good flashcard would be here. This information here. Eight minutes left, okay. Okay. Use and troubleshooting of tracheostomy tubes. Tracheostomy tubes are indicated in patients who require long-term ventilation or who will need a permanent artificial airway. Tracheostomy buttons are small tubes used to maintain an open stoma after the tracheostomy tube is removed. Tracheostomy tubes are placed through a stoma that is created by either surgical incision or percutaneous dilation. Use and troubleshooting of these tubes are described below. Standard trach tubes. Most trach tubes are single-patient cuffed tubes with an outer and an inner cannula. Cuffless tubes, or those without an inner cannula, are used mainly in children. That's a good flashcard because I didn't know that. Cuffless tubes, or those without an inner cannula. So cuffless tracheostomy tubes, or those without an inner cannula, are used mainly in children. When the tracheostomy tube is inserted, a blunt obturator is placed in the outer cannula or tube. The rounded end of the obturator, which extends beyond the end of the trach, prevents tissue trauma during insertion and is removed immediately after insertion. That's a good test question. Flashcard too. The rounded end which extends beyond the end of the trach, prevents tissue trauma during insertion. So a good flashcard could be what is placed in the outer cannula or tube. So what is placed in the outer cannula or tracheostomy tube to prevent tissue trauma during insertion? And then the answer would be a blunt obturator. The flange at the proximal end of some tubes can be adjusted so that the distal end fits properly into the trachea. Twill tape or a Velcro-like neckband attached to the flange. This is the flange, by the way. That is the flange. The flange at the proximal end, blah, 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 blah. Tape or Velcro neckband attached to the flange and placed around the patient's neck secure the tube in place. These should be changed as needed for comfort and cleanliness. If the tracheostomy tube has an inner cannula, it is slid into the outer cannula and locked into place to complete the airway, which is this thing, which is this inside of here. Okay. The inner cannula can be removed periodically and cleaned to prevent the buildup of secretions. A correctly sized spare inner cannula should always be kept at the bedside of the trach patient. Cuffed tubes have high volume, low pressure cuffs, which should be inflated to between 20 to 30 centimeters of water, high enough to prevent leakage type aspiration, but not so high as to cause mucosal ischemia. That's a good one for a flashcard too. Okay. Troubleshooting. Placement should be verified by X-ray. A radio-opaque material is embedded in the tube to facilitate visualization on X-ray. If the tube is obstructed, as evidenced by increased ventilatory pressures or work of breathing, step 1, you clean the trach tube. If present, remove the inner cannula, clean and replace it. Number 2, you attempt to suction through the tube. If it is not possible to pass the suction catheter, deflate the cuff and try again. If this relieves the obstruction, the cuff likely was herniated over the end of the tube. I forgot what that means. Pretty much it's saying the cuff, which is this, was blocking the hole. There's a hole somewhere. There's like a hole right there. And it's saying that this is blocking the hole. Okay, so carefully reinflate it with pressures between 20 to 30 to obtain an adequate seal. If it is not possible to quickly clear the obstruction by these methods, so this is the order. First you do this, then you do that. If that doesn't work, then you do this. Proceed with the obstructed airway protocol and notify the physician immediately, which is another crazy thing. If leaks around the cuff occur, reinflate the cuff to seal the trachea. If the leak reoccurs, Check the pilot line and inflation port for leaks as above. Leaks in the pilot line can be temporarily repaired by inserting a needle with a 3-way stopcock into the pilot tube between the leak and the trachea tube. The physician should be consulted about replacing the tube. If the leak appears to be in the cuff, the physician may have to replace the tube. Ideally, use tube exchange methods to maintain the airway during replacement of the artificial airway, especially if the trach is fresh, because the skin will close up basically. If accidental removal of the trach occurs, if the trach is fresh, the surgeon should be called to replace the tube. Maintain the airway and bag as needed. If the tract has been If the tract has been established, obtain a sterile tube either the same size or one size smaller and use the obturator to replace it according to hospital policy. Obturator and unopened tubes in the same size and one size smaller should be at the bedside at all times. Okay, this is the end of this session.